first presentation will be by Dr. Afifa Nadeem. She's a plastic surgery resident in Aga Khan Hospital.
Assalamualaikum everyone. I am Dr. Afifa and I will be presenting an article with the title of Quantitative Analysis of Lifting Effect of Facial Soft Tissue Filler Injections. It was published in May 2021 in PRS, and these are the authors of this article. I have no financial interest, arrangements, or affiliations that would constitute a conflict of interest. So, it was a prospective cohort study and it was conducted on cadavers and it included 20 hemifaces from 10 cadaveric body donors. The mean age was 83.5 years and body mass index was 25.3 kilograms per meter square. As all subjects were studied in upright position and hyaluronic acid soft tissue filler was used in this study. So what have they done? They have injected temple, forehead, medial mid-face, nasolabial sulcus, and labiomandibular sulcus in supraperiosteal plane. And the lateral mid-face and mandibular angle were injected subdermally. A baseline scan was done before injections, and after 20 minutes of the injection, 3D surface scanning was done. Three separate images were taken and stitched into the 3D imaging. And all of these were analyzed via mirrors software. Changes in local volume and displacement in x and y vectors were calculated. Data analysis was done by calculating the surface volume coefficient, which defines the effect of defined injected volume amount. One value was regarded as efficient and 0 was ineffective. Magnitude of y vector defines the lifting effect of the filler. Regarding results, maximum local volume change was appreciated in chin and labiomandibular sulcus. However, maximum result of coefficient was noted in forehead. Regarding x and y vector, the highest displacement in x vector was noted in temple and lifting effect of the y vector was noted in forehead. We can compose all the strength of this article as they have used the commercially available fillers and the study was conducted by using mathematical algorithm and three-dimensional surface scanning was used so that we can have more comprehensive results. And they have also studied the subjects by keeping the donors in upright position, which has prevented us from biasing the results from the gravity effect of the fillers. We can also mention few weaknesses, which are that all the subjects were old age, and this study was conducted on cadavers, which is different from living body as cadavers lack blood pressure, muscle tone, and there is a change in temperature. Also, the results were different for different in the sense that it would be challenging for generalizing the results for living people as we have different uh, aesthetic requirements for living bodies. A clinical implication of this article was that the filling effect of filler was used to study the lifting of the face. And we can also have future research in this regard that we can study these objectives on living objects, on younger candidates, and by using the larger volume of the fillers. Thank you.
So this is the brief introduction to the article. Thank you very much, Dr. Afifa. It is now open for discussion. Anybody would like to give their opinion on this article? Professor Salah, would you like to give an opinion, start giving an opinion before we can have?
Hello, Dr. Zia, and thank you for everybody for attending today. And I would like to thank for the authors for the article and the presenter also. I just want to ask the presenter about what limitation was there for the article? They didn't mention any limitation.
Yes, what I understood for the limitations was the authors have themselves mentioned that this study is on cadavers, and cadavers are very different from normal human living tissue. So their reaction might be in some ways different. So that is, I think, a major limitation of this study. What I feel are the strong points or the major strengths of this study are that I think this is the first time anybody has demonstrated the lifting effect of fillers. I have experienced this myself in my clinical practice, and I'm sure a lot of other people would have experienced this as well. Till now, before this reading this article, I was unable to actually connect this lifting effect to the filling in the temporal area. I was generally filling in the area which was backed up by the bone, like in these areas. I gave a presentation on this, that in the maxillary area and the temporal area, I was doing a lot of filling, and it did result in lifting up of the jowls. I discussed it with a couple of experts in the field of facial fat grafting, and they were not convinced that this could result in a lifting effect. But what I experienced in my actual clinical practice was that there was, in effect, a lifting effect. So I think this is the first study that has given an objective analysis of the lifting effect. Professor Sameh Al-Nomani is here and he has raised his hand. Yes, Professor, we would like to hear from you.
Hello, Zia. Do you hear me well?
Yes, we do. How are you?
Okay, fine. Thank you. How's life in Pakistan?
Very good to see you. I'm very happy to see you. Please, what would be
Thank
your
you. Okay, I got a chance to practice a lot of fillers and a lot of applications of fillers in the face. And I had some publications about the lifting effect of fillers of the face comparing to surgery. And of course, there were a lot of applications tackle this object, starting from the question by Lamprose about facial aging, whether it is deflation or descended tissues. This is the first question we have to answer. Yes. The aging of the face, is it deflated or descended? I think there were a recent publication done by Rarek, I think last month or 2 months, couple of months before, about this point, whether it is deflated or descended. And he tackled the topic of deep fat and superficial fat. And he stated that the deep fat is to be deflated, and it is the actual support of the superficial fat, then the superficial fat will be descended. There was an old paper, I think it is 2006, about the lifting effect of the fillers. And they acted along the ligament line of the face, which extends from the lateral orbital margin, temporal fossa, then to the zygoma. The most prominent point was the zygoma, then to the point over the bony mandible. This is the ligament line, and this states 4 ligaments, which are the retaining ligaments. So if you injected fillers just in this line or lateral, This anatomical area is characterized by layering. It is well-defined layers. If you injected fillers in this area or just lateral in two planes, what is called dual plane injection, it will produce some crowding in these layers so that it produces lifting effect. This was described by, I think, a dermatologist. But as described by Rarick, the theory is to inflate the deep tissues that it will left the superficial tissues. For me, the weakness of this paper that is what did he mean by cohort group? Is it cadavers? That they are all cadavers? That's what I want to ask. I think it is very difficult to judge on cadavers because the skin of cadavers is very heavy and they are preserved, I think, by fluid preservation. So even the tissues of the face is well moistured by fluids. It's bad judgment to judge the lifting effect over a cadaver. Unless it is very fresh cadaver, it's just killed. The second point, he didn't state the technique. I didn't read the paper, by the way, but he didn't state the technique of injection. Was it all deep or just he injected in two planes? The fillers, he didn't state the type of fillers. Sorry?
It was deep, supraperiosteal.
Sorry, I can't hear.
It was deep injection,
Okay,
supraperiosteal.
it was described in two planes, Muhammad. It was described in two planes, just subperiosteal and another more superficial plane. It was described as dual plane injection. And a lot of fillers were described for this technique, but they have to have J-lifting effect. This is a technology for describing fillers related to the size of particles and the crowding of particles. So he didn't state what fillers he's using. He has to state what fillers exactly, and are they all the same? What their size particles, what their J effect size, and the result. Was it long lasting? So I think it needs to be on patients, not cadavers. And overall, I thank you very much about this great idea and this great way of practicing and exchanging informations. Thank you.
Dr. Samah, do you think it's similar to MD codes?
So let me clarify a few things. Yes, he used a commercially available filler. I think it was Perfecta. I think it was Perfecta, and the same filler was used in all patients, the same viscosity. Yep, it was Perfecta, and it was used in all the patients. He described two injection depths. One was supraperiosteal, and the other was more superficial in the subdermal plane. So as you mentioned, he did recognize these two types of injections. The interesting thing was that filling deep in the temporal area, supraperiosteally, did not result in any lifting effect. The Y quadrant, as he describes it, which shows the lifting effect, had no effect while being injected in the supraperiosteal plane. The lifting effect was only present in the subdermal plane, subcutaneous plane. So the superficial injection in the temporal area had the most lifting effect. And agreed, these are all cadavers, and he himself has mentioned that this is the severe limitation of this study, that cadavers do not behave the same as healthy living people.
Is it more or less similar to the MD code techniques of injection?
Yes, more or less similar to the MD code.
I think MD codes is a commercial term. It's meant to be for the beginners, just to learn or to teach them how to inject. But for us, for better understanding, There are lifting points and there are filling points. Yeah, it's very interesting to know that Lamprose, who was the first one to describe descent versus deflation, he described this on the same patient, and he followed up her along 20 years, you know, but he was meant to follow up her about the aging mechanism of aging. And this patient has a pigmented mole over her cheek. And he noticed the location of this pigmented mole along years, over 20 years. And he discovered, or he noticed that this point location didn't change. So his theory that the mid face undergo deflation rather than descent. And this go with the recent publications about facelift that mid face cannot be lifted. You remember the max technique that described by Patrick Tonar. He described first by 3 anchoring points: mid face, lower face, and neck. Then he canceled the point of mid face, or the anchoring point of mid face, and he replaced it by injecting microfat or melifat. And he stated that the suture, or the anchoring point suture, doesn't produce any notable effect over the mid face, and it should be filled rather than elevated.
Yes, and a quite similar point has been made in this article as well, that the medial face has more filling effect and no lifting effect. So almost a similar point in this article.
Okay, it can agree with the paper I read in 2006 about that the lateral face is anatomically divided into layers, well-defined layers, while the medial face, the layering anatomy of the face has changed into interlacing layers. They are not layers. So when you inject just medial to the line, the ligament line I told before, you are filling. When you inject over this line or lateral, you are lifting. And this is just the borderline which you change your technique or your target.
Yeah. The lifting effect can be obtained by injecting superficially in the lateral face, and not
Exactly.
by injecting in the medial face. The medial face injection will only restore volume and increase projection, not the lifting.
Exactly.
So I think that's a good learning point for all of us. Any other point anybody else wants to raise in this article? I personally feel that this is one article that can have impact on practice. If there are no further questions on this article, I think we had a very nice discussion. Thanks to Professor Sameh Al-Nomani. Let us go to the next presentation. That again is a very interesting article, although again an aesthetic topic. And Dr. Aisha Jamil will be presenting on the next paper.
Hello, Assalamualaikum. This is Aisha Jamil. I'm a postgraduate resident plastic surgery department, Afan Hospital. The article I'll be talking about today is titled as Cone Beam Computed Tomography, a user-friendly practical roadmap to the planning and execution of every rhinoplasty, a 5-year review. It's recently published in the Plastic and Reconstructive Surgery Journal in the May 2021 session. These are 3 authors of the respective article. There is no conflict of interest between this publication and our work. It's a retrospective cohort study which reviews 5 years of work experience by the senior author in the field of rhinoplasty. It's a single-center experience-based study spanning duration of 5 years, which started from September 2014 and lasted till March 2020. Population size included 586 procedures, including primary and secondary rhinoplasty. Primary being 335 and secondary being 251. Inclusion criteria kept for this study was all patients were aged above 15 years. And secondly, all patients who underwent rhinoplasty had their cone beam computed tomography imaging done as preoperative imaging from their own center, from the center of the respected author. Exclusion and criteria: patients who underwent rhinoplasty had conventional CT scans done from obtained elsewhere were not included in the study. After brief discussion about the scanner, the machine, the kind of machine and how it obtains imaging and how it reconstructs those images, the author discussed few instances where anatomically detailed images were taken, and he concluded that cone beam computed tomography is a very user friendly and quick to obtain easy imaging, which can have significant clinical impact and cost effectiveness. Apart from its effect on improvement in functional and aesthetic outcomes, it can be a very valuable tool for adequate assessment in insurance and medical legal kind of purposes. Also, it can be very handy for patient education and effective visual communication. Few strengths of this study that needs to be discussed is a pretty good sample size, constituting around 700 surgeries. It also it studies effect on both functional and aesthetic outcomes, and it has reproducible data and results, and a very vast imaging data is available alongside. Few weaknesses of this study are that it's a single center experience based study. It provides insufficient statistics regarding which particular information from which particular patient was used to have that outcome to the changed outcome, and it's essentially a subjective assessment of a single person. Clinical implications that it can have in our practical clinical life is that it can be used for better visualization of skin intricacies and contour compared to the underlying framework. That can help it decide and formulate a plan individualized to each individual, giving clear indication to our limitation and targets. It can help us formulate plan regarding osteotomy and osteoplasty. Another useful aspect of it is that it minimizes radiation exposure in comparison to a conventional computed tomography scan, almost 1/10 of it. One drawback in its usage is that it limits use in private setup due to its cost. Areas that need future researches to be done in is that it should be done in prospective study manner and should include experience based in multiple centers. Thank you, everyone.
Thank you.
Any questions, everyone?
Yes, I would like to ask about the study and its limitation also. Was there any comparison between before and after, the same study before and after, to compare the result and how its implication?
I'm sorry, I couldn't understand your question. Before and after of what?
He did scanning before surgery, okay? But he didn't compare this result after surgery for the change in the skin and so on. And again, the skin usually takes some time for the edema to settle down after surgery for rhinoplasty.
Who wasn't? There wasn't any specific case presented in this study. He has shared a lot of data, pictorial description of many scans that were done, showing many deformities that are being clearly shown in that imaging, but there's no post-op scans available, which is one of the limitations of this study, that we don't have any follow-up on that patient. And the point which was mentioned in the limitation, that there's no comparison exactly about the which deformity was clear in this scan and what exact surgical intervention was taken for that, and how much it was reformed or how much it was corrected after that. Hope that answers your query.
Yes, okay.
Okay. After, sir.
I would actually love if some resident can give his opinion on whether they think this is a good study, an average study, or not a good study at all. I would like to.
Excuse me, Colonel Zia, I do have a question. Can I ask?
Yes, of course.
Sir, is it helpful, this cone beam CT scan, in only those rhinoplasty that only required cartilaginous workup? Can it help us?
Yes, they are able to visualize the cartilaginous deformity as well, which is generally not very well visualized in a conventional CT scan. So this is a strength of this machine.
Thank you, sir.
Uh, is it a good paper or is it not a good paper? I would like an opinion from the resident. Professor Samay seems has left.
It's difficult to say good or bad, but there should be critical appraisal for items about for each article. There is some items to and checklist to confirm.
Yes, and that's what I want people to think critically. That what boxes does this study check, and what boxes are not checked by this study. Anyone volunteering to give an opinion on this article?
Let's help each other by what is the type of the study?
Yeah,
The type of
anyone?
the the type of the study, the aim of the study, the methodology.
Yeah, तुम बताओ ना.
So it's retrospective cohort type of study.
It's okay. This type of studies is suitable for diagnostics or investigation or something like that. Is it suitable for its aim?
So it's the study is essentially based on a person and himself, single person's experience, not very much supported by data followed post-operatively.
Okay, for the sample size, you said it's a good sample size. How we can decide if it's a good or bad sample size?
कुछ बीच में से miss हुआ है। Sorry.
I don't need your answer. I'm just leading our
Yeah,
colleagues to proceed.
the problem is we are four people in one room and we have just one computer, and that too has a faulty speaker, so we have to put on the headphones each time to give an answer. And when one is listening, the other cannot. So my take on this article, if nobody, Fahim, are you responding?
Yes, sir. I think so. This is a good study because conventional CTs does not help us in planning for cartilaginous workup. So as you have stated earlier that this cone beam CT scan is meant for analyzing cartilaginous deformity as well.
So my take on this study is that it's a retrospective study. There are no groups. It's just one group analysis of what they have done. Uh, it's more of a opinion rather than a result. It can be classified as an expert opinion, which is the lowest level of evidence. So there is no evidence that can be gained for it. It cannot be quoted as an evidence for anything. It is just an expert opinion. The author feels that having done so many CT scans on so many patients, I feel that it has an edge over not doing it. It does not compare it with the conventional CT. It does not compare it with not doing a CT scan. It does not give any indication whether doing this investigation leads to any improvement in the outcome. This matter cannot be judged from this paper. As far as adopting this practice in our own setup is concerned, uh, that doesn't even start as a question because it's a very, very expensive equipment and it is available in very extremely few research centers. I think there are 2 or 3 centers where this cone beam is available for nose CT scan. So,
So,
in my personal opinion, it's a very low evidence is provided by this study. It does not add much to our evidence base. It just provides us with the introduction to a new tool. Maybe in some future study, someone compares patients that have done this cone beam and patients who were not subjected to cone beam. Was there any difference in the outcomes? Was the surgeon feeling more comfortable if they had this investigation before? Were the outcomes better? I think in future it may define its role, but this study, in my opinion, does not define the role of cone beam CT scan in rhinoplasty. I personally uh, don't even get a CT scan done, although I have seen many presentations in which a lot of presenters have very clearly prove that a CT scan at least is essential in patients with nasal obstruction or previous history of trauma. They feel it is essential. I am personally not getting it done. I'm not sure what is the opinion of others in getting a CT scan for a before a rhinoplasty. If anybody would like to give an opinion on that.
for our colleagues, on the group of the Telegram, we can also share some of the checklist, a link for a checklist according to the for critical appraisal of different articles. It will help you to go through and check if the article is fulfilling the items or no, and so on. It will be also helpful, depend on systematic review, cohort study, case control, case report, and so on. We have a different checklist and standard checklist for critical appraisal of article. I will share on the Telegram group.
Thank you very much, Professor Salah.
So, can I add something to it?
Yes,
Dr.
of course.
Mustahsen here.
Yes, yes.
Yeah.
Thank you
So
very
sure.
much. Go ahead.
So I was keenly listening to all the points which have been discussed. I agree with your appraisal or with your assessment of this article, and I think a few things residents should know that we can't say it as an expert opinion. Obviously, it has certain methodology, so it is above as an expert opinion, and it is a typical retrospective cohort study. But in a retrospective cohort study, there is always a comparison group, and which is missing in this article, and there are many technical flaws in this study regarding if I consider it as a reviewer or as an editor, because they have mentioned it as a retrospective cohort study, which it doesn't look like as our discussion. So that it means the study design is not appropriate. But as regards the clinical application, whenever we are discussing a study in a journal club, so the most important point is how it will change our practice or how it will affect our practice. And I totally agree that currently the data provided in this study or the conclusions which have been made does not add anything to our clinical practice or does not change our clinical practice of having a cone beam of all the patients. One thing I would like to suggest with regarding this journal club is that as it is being recorded, so an excellent letter to the editor can be generated from the discussion which takes place in this journal club. So a food for thought, and I think that the points which we have discussed can result in an excellent letter to the editor, in which we can mention the future prospects of the study or its significance in clinical practice. So that is my suggestion, that we should always consider this discussion as ultimately formulating into in a letter to the editor. So this is my take on this article. Thank you very much.
Thank you very much, Professor Mustasan. That's fantastic. This is actually what I was looking forward to when starting this journal club. Opinion from people like you on how to analyze the paper. Thank you very much for that, and the excellent suggestion that yes, we can generate a letter to editor based on our discussion today. It's being recorded. Anybody who wants a link to the record, it will be available, and anybody keen enough to initiate that is most welcome to do that. Now, before we end, if there is any other opinion, I would most welcome that.
Yeah, one more suggestion for this is that as someone has pointed out, I think Professor Salah has pointed out about the checklist. So if our presenter can, at the beginning or at the end, he or she can